Sorry for the interruption. I'm not a surgeon, I'm a cardiologist, specialized in the endocardial treatment of cardiac arrhythmias. So it's really an honor to be here in this very interesting meeting to speak about our personal experience using robotics for endocardial ablation of arrhythmias in Maastricht also. So this is the agenda of the topic I have, and I would like to discuss these points together with you. So first of all, to point out what are the frequent cardiac arrhythmias we are confronted with, talking about the basic EP concept. I think that's important to understand how our procedures are built up. Then talk you through the several robotic systems we have, and especially the system we use quite often in Maastricht. And finally, what is the available data to support using these systems, at least for the endocardial ablation procedures. So the two main arrhythmias we are confronted with these times are atrial fibrillation and ventricular tachycardia. Atrial fibrillation is a very common problem in the millions of patients throughout Europe and the States, and a lot has to do with the aging population, basically. VTAC is another arrhythmia we see quite often, and that has to do with the fact that a lot of patients do survive their myocardial infarction. So this means that most of those VTACs are in the setting of an ischemic cardiomyopathy, and it's a very important problem. So if we just take a look at the basic EP properties of those two arrhythmias specifically. In the case of atrial fibrillation, this is a landmark paper from the New England dating from '98, and the group in Bordeaux, Michel Heisseguer, learned us that the main trigger of atrial fibrillation are the pulmonary veins situated in the left atrium. So if one wants to tackle the AFib in a given patient, tackling those PVs will be the cornerstone of the ablation. And that's shown in this slide. So I will talk you through it. This is the way we do it in the EP lab when you do it by hand. So it's a venous access via the groin. We perform a transeptal puncture, and we basically have two catheters within the left atrium. One is the so-called lasso catheter seated within the pulmonary veins. Using this catheter, you can record signals, and those signals are learning us whether the ablation is complete or not. And you have a steerable catheter, most of the time using radio frequency energy. And on top of the slide, you can see those so-called electroanatomical mapping systems. So this is a merge of a CT and a map created using these catheters. And the red dots are the lesions we've made. So we performed a so-called wide antral catheter ablation, isolating the PVs in ipsilateral pairs. So this is an AP view, this is the posterior-anterior view. There's a common ostium on the left, right superior, right inferior PV. And you can see that after the last ablation, all the signals disappear. So that learns us that the PVs are isolated, and once more, this is the cornerstone of AF ablation. In some patients, we want to perform linear lesions, especially when you have a more persistent form of atrial fibrillation. And performing linear lesions can be very tricky and difficult if you do it by hand. And making linear lesions is something we learned from the cardiothoracic surgeons. And we have sometimes to make a lot of linear lesions. Once more, sometimes very, very difficult, because you have to cross difficult areas as the mitral isthmus, which is a region between the mitral annulus and the left inferior PV. Again, here presented on a electroanatomical map. So that's for atrial fibrillation. When we switch to VTAC, it gets even more complicated, because the infarction is not homogeneous. You have a lot of surviving myocardial bundles within that scar, and that's actually the problem, because all those myocardial surviving bundles are potentially reentrant circuits. So it gives us a very complicated, let's say, target to find and to ablate, especially when you do it by hand. And once you have a catheter within the left ventricle, we have to look at very, very small signals indicating where those surviving bundles are situated. So it can be very, very time consuming and very difficult to ablate. especially once more when you do it by hand. To reach the left ventricle, you have two axes actually. You can do it also via a transeptal axis via the left atrium within the left ventricle, or a retrograde approach over the aortic valve. But once you're in the left ventricle, it can be difficult because you have a lot of travicularization. So, what about the robotic systems? Actually, there are several commercially available systems to perform endocardial ablation. You have the Stereotaxis system, the Amigo system, and the Hanson Medica system, Sensei robot. That's the one we use, especially use in Maastricht. The Stereotaxis system is basically made about two huge magnets besides the patient, and you have to use also a V-drive, which is a kind of two motors to advance the catheter within the left atrium, and once you're in, you can use the magnets to steer those special catheters, which are quite expensive. The problem with this system, it's very expensive. You need a special sealing because each magnet weighs about 1 ton. And sometimes using this system, contact force can be an issue. You cannot dictate the force you want to have the catheter on the tissue. The other system is the Amigo system, which is basically a robotic arm besides the patient. It's an open platform, which is an advantage. You just mount the catheter and you can use the catheter using this toothbrush-like device, but you're restricted to the possibilities of the catheter. It's kind of a rear-wheel drive system, so you push the catheter. Once you're in, you have limited motion possibilities using this system. That's why in Maastricht we opted for the Hanson Medical system, which is a robotic arm besides also the table of the patient. And we use this system outside the EP room, so you're not exposed to X-ray. And the big advantage of this system is it's using a steerable sheath, which is made up of an outer and inner guide, as you can see here. So it gives you a lot of motion capabilities once you're inside the cavity, and it's an open platform. You can use radio frequency. Cryo is also possible. Short movie just to show you how it works. So that's a robotic arm. Once we have a transeptal access, so we're inside the left atrium, and this is sort of very, very small and precise motion of the system. We use the system outside that room using this tripod system. We have all screens available just in front of us, so we're completely independent of somebody else. And you can leave it. So once it's on the right place, it stays there. And you have a little brake system here just to be sure it makes the exact movements. So that's first a very, very big advantage. You're not within the room, so you're not exposed to X-ray, and you can sit during the procedure, especially when you know a VT case can take about 4, 5, or 6 hours. It makes a big difference when you just can sit. And there you can see the radio frequency catheter within the left atrium, left atrial appendage, left superior PV, and I'm performing the ablation seating, which is a big difference. These are the kind of ablations you can perform using robotic system. This is an AF ablation, so you're looking to a left atrium using an electroanatomical mapping system. It's a PA view, so those are the left veins, those are the right veins, and each red dot is a lesion that you've made. If you would do this by hand, it would take about 3.5 to 4 hours. This is done within 1 hour, so a huge difference with a good contact also. This is a complex VTAC case in a patient, so you're looking to a representation of a left ventricle. Purple color represents normal tissue, red color is the infarction, so you have a huge anteroapical infarction. And all those red dots are representing, going one back, we're representing ablation dots or ablation lesions we've made. So if you would do this by hand, it would take you like hours. This is done in little more than 1 hour. The robot can also be used in complex cases that have undergone surgery before. So what you see here is a patient that had a mitral valve replacement, has also an ICD on board. This is a shock lead, this is a lead in right atrium. You see a catheter in the coronary sinus here, and one here on the bundle of his. Here you have the prosthetic mitral valve, and we do inject some catheter within the left atrium. So performing this procedure by hand would be very, very tricky because you don't want to get entrapped in this valve, obviously, but performing this with a robot is quite easy and safe. So what about the available data? Because those systems are expensive and we have to convince payers inside the hospital these systems are good to have in your institution. So the biggest registry we have concerning AF ablation using robotic system is this registry. Something more than 1,700 patients were included. Nice distribution between paroxysmal persistent and long-standing persistent AF, normal ejection fraction and somewhat dilatation of the left atrium. What's interesting to see is that looking at complications, it was very, very comparable to procedures performed by hand. So if you're looking to tamponade, pericardial effusion, it's less than 2%, which is very acceptable. And bleedings at puncture sites, 1.5%. Again, very, very comparable to procedures done by hand. Also interesting to see, looking at the data, is they make a distinction between high volume and low volume centers. And they show that you have a steep learning curve, complications went down, success percentages went up, so quite interesting to use these systems. We also have limited data about using robotics for VTAG cases, as I've shown you one case. So if we look at the advantages of using these systems, there are several advantages for sure. First of all, there is the manipulation of catheters to precise locations within the heart and keeping them stable, which is quite difficult if you do it by hand. It's achieving adequate tissue contact is very important. If you have poor contact, you know that the lesions will not be transmural, and it's something we absolutely want to have. It allows us to perform most of those procedures not being exposed to X-rays. And it has been shown that using these robotic navigation system do reduce fluoroscopy times in catheter ablations for AF. There's one important trial that's going on now. We don't have results yet, which is the man versus machine trial, during which patients are randomized to catheter procedures done by hand or using those robotic systems. So we're still waiting the outcomes of this trial, and they will be important. It's very important to state that it's still a machine, so interpreting those signals I just showed you during AF ablation or VTAG is still the responsibility of the EP. So it just helps us to perform the ablation, at least to make the lesions, but to know where you have to deploy the lesions, it's still up to the EP. So ladies and gentlemen, this brings me to the conclusions of my talk. So I try to show that AF and VTD is really the core business in modern cardiac EP. Both these arrhythmias have specific mechanisms. It's important to understand them, to know where you should deploy the lesions. We do have several robotic platforms with their advantages and disadvantages. Using robotic system definitely has important advantages over procedures done by hand, and we're still eagerly waiting for the results of randomized trials. Thank you very much for your attention.